Good evening, everybody. Welcome back to Focus the Future Dentistry free webinars. Today's webinar is on traumatic injuries in the primary dentition by Dr. Sherin Jose. She completed her BDS from GDC Calicut and MDS from R. Beslis Dental College, Kodamangalam. She got Research Peace Award for Best Researcher in Pediatric Dentistry. There are many publications under her name in both national and international journals. Welcome, ma'am.
Thank you, Dr. Hima, again for your kind words. So this is the 33rd free webinar series of Focus and the third free webinar on pediatric dentistry. So I think we'll start with today's session. So today the session will be on the traumatic injuries in the primary dentition. I hope I'm audible to you all. Can you all hear me? There is no problem with my audio, right? Okay, so we'll start with today. So my reference note for the session today is from the dental trauma guidelines that is given by the International Association of Dental Traumatology that has been endorsed by the American Academy of Endodontics as well as the American Academy of Pediatric Dentistry. So you all know trauma is a very repeatedly asked question, and today we'll be discussing with trauma affecting the primary dentition. The various aspects in management, the clinical things that you have to know, everything will be discussed today. So this is an important session for you. So we'll start with today's session. So the first thing that you need to know is that the most of the dental injury, the most likely age is during the first 2 decades of life, and that too within 2 to 3 years is the most commonly, it's the most prone age for a dental trauma. And at the same time, you know that a trauma is more seen in boys when compared to that in girls. And the most frequently affected tooth in dental trauma is definitely your maxillary central incisors. Then comes your lateral incisors. And the most commonly seen trauma in the primary dentition is the luxation injuries. And at the same time, in the permanent dentition, the most commonly seen traumatic dental injury is the crown fracture. Okay, so keep this in mind. The most commonly seen injury in the primary dentition are the luxation injuries, and in the permanent dentition, it is the crown fracture. So when it comes to the traumatic dental injuries affecting the primary dentition, certain things that you have to keep in mind is that you need to know these things because definitely they will be in your options in various problem solving questions. So the first thing is your pulp sensibility or your pulp vitality test. You all know they are unreliable in primary tooth and they are not recommended. Following trauma, you'll be getting varying results. So because of that, the pulp sensibility tests are considered unreliable in primary teeth and they are not recommended. And whenever you get a question, you need to pay attention to the mobility. If they are mentioning anything about the mobility, the color of the tooth, if there is anything, any reaction or tenderness to percussion or on manual pressure, the position or the displacement of the tooth, everything should be kept in mind. Then only you can point out to the correct response of your question. And you should know that discoloration is a very common complication following any luxation injuries. I have mentioned the most common injury that you see in primary dentition is luxation injury, and most commonly you see discoloration also in the case of a primary tooth. Now we'll see the discoloration in primary tooth following trauma, usually they will fade and the tooth will regain its original shade in a week or month. So unlike in permanent teeth, where most likely your management option for discoloration is RCT bleaching or anything like that, in the case of a primary tooth, root canal treatment is not indicated for discolored tooth unless or until there are clinical or radiographic signs of infections of the root canal system. Okay, you have to prove that there is a clinical or radiographic sign of infection affecting the root canal system. Then only you go for a root canal treatment in the case of a primary tooth following dental trauma. Okay, keep this point in mind. Now, whenever there is an injury to the primary dentition, what is your management strategy? The first and the most appropriate option in emergency situation is definitely observation. Okay, observation of the affected tooth, and you wait and watch is most likely the most appropriate option in the emergency situation unless there is a risk of aspiration, ingestion, or occlusal interference. Okay, I hope I am clear to you all. Whenever there is an emergency situation, the most appropriate option in the management of dental trauma in primary dentition is observation. Okay, now the next thing that you have to keep in your attention is about the risk of primary dentition could lead to a permanent dentition. You all know the primary tooth, it is always an association. When sometimes the trauma might be occurring during the time of formation of the permanent tooth bud. So it can definitely affect the permanent tooth bud. So whenever you get a question or whenever you get anything, you always should keep in mind about the erupting permanent tooth that is next to your primary tooth, which could also be affected with the trauma that has occurred due to in the primary tooth. Now, first we'll see the classification of dental trauma. So this is the most commonly used classification, that is the Ellis and Davey classification. So most of you will be knowing this. This is one important question in your undergraduate days. Okay, so you have 9 classes according to Ellis. Class 1 is an enamel fracture. Class 2 is enamel and dentine fracture. Class 3 means fracture involving enamel, dentine, and pulp. Class 4 is a non-vital tooth that has become non-vital due to trauma. Class 5 is avulsion. Class 6 is root fracture. Class 7 is displacement of the tooth with either crown or root fracture. Class 7 is the fracture of crown end mass and its displacement. Class 9 is the traumatic injuries in the primary dentition. Okay, so I repeat, class 1 is enamel fracture, class 2 is enamel dentine fracture, class 3 is enamel dentine and pulpal fracture, class 4 means the tooth has become non-vital, class 5, very, very important for you, avulsion, class 6, it is root fracture, class 7, it is a displacement of the tooth with neither the crown or root fracture, class 7 means fracture of the crown end mass and its displacement, Class 9 means traumatic injuries to the primary dentition. So keep in mind, whenever you get a primary tooth trauma, that falls in class 9. Okay, so I hope I am clear to you about the Ellis and Davey classification. Now, the next thing that you need to know is about the injuries that the injuries that you see in the periodontal ligament area. So these are the common 6 injuries that can happen in the periodontium area. So the first injury is concussion. So concussion means it is an injury to the tooth supporting structure without abnormal loosening or displacement of the tooth, but with marked reaction to percussion. Okay, so there is no displacement, no mobility, but you can see a marked reaction to percussion. So you keep in mind concussion, percussion. Okay, so in concussion, there is no mobility, there is no displacement of the tooth. What you see only is the marked reaction to percussion. Concussion, percussion. You should remember, you can remember like that. Now, the second injury that is affecting the periodontal tissue is subluxation. So the name says it's all. What is subluxation? Luxation means there is some kind of mobility. That is, it is an injury that is affecting the tooth supporting structure with abnormal loosening or mobility of the tooth, but without displacement of the tooth. Okay, so in subluxation, you see mobility, but no displacement. Okay, now the third type of injury is the extrusive luxation or peripheral dislocation, or otherwise called partial avulsion. So extrusive luxation means the tooth is displaced out of the socket. Okay, extrusion means the tooth is displaced out of your socket. So the tooth is mobile and also it is displaced. Okay, tooth is mobile and it is displaced. This is referred to as extrusive luxation. Now, the fourth injury is lateral luxation. Lateral luxation means it is the displacement of the tooth in any other direction other than axial. See, axial direction means, what are the injuries that coming in axial direction? You have extrusive luxation, that is tooth displaced out of the socket, and then you have intrusive luxation, that is tooth displaced into the socket. All these falls in the axial plane. Any other direction of displacement of the tooth, you can refer it to as lateral luxation. Okay, now the fifth type of injury is the intrusive luxation. Intrusive luxation is otherwise referred to as central dislocation, and is the displacement of the tooth into the alveolar socket. So whenever there is an intrusion injury, especially in the primary dentition, you keep in mind about the erupting permanent tooth bud that is present. Okay, you should have that point in mind whenever there is an intrusive luxation. So whichever response you are marking in your answers, you should keep that in mind. The permanent tooth bud is right on top of your primary dentition. Okay, so intrusive luxation, it is otherwise referred to as central dislocation. Now, the sixth type of injury is avulsion. That is the most commonly or repeatedly asked question, which is otherwise referred to as X-articulation. It is the complete displacement of the tooth out of the socket. Okay, so I hope I am clear to you about the injuries to the periodontal tissue. So you keep in mind, concussion means percussion. There is no displacement and there is no mobility. Subluxation means the word luxation comes. So there is movement or the loosening of the tooth. Extrusive luxation means you can see extrusion, that is the tooth is moving out of the socket. Then you have lateral luxation. Then you have intrusive luxation, that is displacement of the tooth into the socket. And finally, you have avulsion. Avulsion means it's a complete displacement of the tooth out of the socket. So these are the 6 injuries that you see affecting the periodontal tissue. Intrusive, is there any confusion in intrusive luxation or intrusion? Am I clear to you regarding intrusive luxation? Difference between extrusive luxation and avulsion. Extrusive luxation, see, it is partial avulsion. Avulsion means the tooth is totally out of the socket. At the same time, extrusive luxation means it is only partially out of the socket. I'll come to that in detail. I'll show you with the pictures, extrusive luxation, avulsion and all. That will be shown again in your, in the coming sessions. We'll be discussing in detail about each injury and how we manage it. This thing is typically you can easily you can study this up. Concussion, there is marked reaction to percussion. Then you have subluxation, extrusive luxation, lateral luxation, intrusive luxation, and avulsion. We'll be coming to detail in each of these injuries. So we'll first see all the hard tissue injuries first. So the first injury that you need to know is about the enamel fracture. So you can see in the picture, there is a fracture of the enamel. So whenever there is an enamel fracture, how will you manage an enamel fracture? It is just by smoothing any sharp edges if present. That is how you manage an enamel fracture. You smoothen any sharp edges that is present. That is enough for an enamel fracture. If it is an extensive enamel fracture, you can go for restoration of the tooth also. And you avoid and you give proper patient instructions like advise soft diet, then better soft toothbrushes are advised, regular mouth rinsing is advised. All this comes along with the enamel fracture. Okay, now the next type of injury is the enamel dentine fracture. So remember, enamel dentine fracture in the permanent dentition, it comes under LS class 2. Okay, so in the case of a primary dentition, trauma to primary dentition comes under which LS classification? Trauma to the primary dentition? Yes, it is the class 9. So now we are discussing only about trauma to the primary dentition. Okay, this is not about trauma to the permanent dentition. Today we are discussing only about trauma to the primary dentition. Now we'll see about the enamel and dentine fracture in the case of a primary tooth. So in the case of a primary tooth, where if there is an enamel and dentine fracture, what you do is that you cover the exposed dentine with either glass ionomer or composite. Then you restore the lost tooth structure with composite immediately, or you can do it in a recall visit. This is how you manage an enamel dentine fracture in the case of a primary tooth. You cover the exposed dentine with glass ionomer and composite, and you restore the lost tooth structure with composite immediately or later. Okay. Now, moving on to the complicated crown fracture. When do you call a crown fracture complicated? You call a crown fracture complicated when it is involving your dental pulp. So here you can see that the fracture is involving the enamel, dentine, and pulp. Shubham, which topic should I repeat? Enamel fracture. Enamel fracture is the most simplest fracture to manage. Whenever there is an enamel fracture, you can smoothen any sharp edges if present, and you give proper patient instructions like soft diet is advised, soft toothbrush is advised, and also regular proper mouth rinsing and everything is advised. Is that clear to you about enamel fracture? You smoothen the sharp edges if present. That is how do you manage an enamel fracture. And if a large portion of enamel is lost, you have to replace that lost tooth structure with composite. I hope I am clear to you. And now we'll move on to the complicated crown fracture. So a complicated crown fracture means it is a fracture involving, no, you call a fracture complicated if the fracture is involving your dental pulp. So you can see that in this picture, the fracture is involving the enamel, the dentine, as well as the dental pulp. So whenever it comes to the pulpal involvement, always your aim should be to maintain or to preserve the vitality of the dental pulp. And that is done by partial pulpotomy. Okay, whenever possible, you should always keep in mind that you should attempt to maintain the vitality of your pulp by partial pulpotomy, and the suitable material used is calcium hydroxide. So according to the International Association of Dental Traumatology's trauma guidelines, the suitable material for doing a partial pulpotomy in the case of a trauma is calcium hydroxide. So what you do is that you place a calcium hydroxide paste over the pulp. Here you place a calcium hydroxide paste, then you cover it with GIC, and finally you restore it with composite restoration. Okay, extraction is the alternate option if you cannot go ahead with other, if you cannot maintain the tooth vitality, then only you go for extraction. So keep in mind, complicated crown fracture means fracture involving the dental pulp. So whenever pulp is involved, your aim should be to preserve the vitality of your dental pulp. And then your treatment option will be partial pulpotomy. The agent preferred is calcium hydroxide. You place calcium hydroxide over the pulp, then you restore it with GIC and composite. And as a last result, you go for extraction. See, yes, calcium hydroxide is mostly avoided in primary tooth as it will lead to internal resorption. But according to the IADT guidelines, the suitable material to do a partial pulpotomy in primary dentition is calcium hydroxide. We generally don't do a pulpectomy. Whenever possible, you should try to maintain the vitality of the pulp. What will you get if you just devitalize the tooth? Always your aim should be to preserve the vitality of the pulp. Then only, if you are not able to maintain the vitality of the pulp, then only you go for extraction or anything, extraction, pulpectomy, or to the other options. Your prime option should be to maintain the vitality of your pulp. And that is why you do a partial pulpotomy. Whenever possible, you do a partial pulpotomy, and always consider extraction as an alternative option. You do RCT in primary tooth following trauma only if you see any clinical or radiographic signs of radicular pulp infection. Okay, I hope I am clear to you all. Now we move on to the next set of fracture, that is the crown root fracture in the case of a primary tooth. So crown root fracture, it can occur in these two ways. So either it can involve the enamel, the dentine, as well as the root without involving the pulp. Sometimes the crown root fracture can be like, it will involve the dental pulp also, like shown in the second picture. Sometimes in crown root fracture, the pulp is saved. Sometimes the pulp is involved. So crown root fracture may or may not involve your dental pulp. So in emergency situation, the most appropriate management for a crown root fracture affecting your primary dentition is no treatment. And in an emergency basis, if you're going to if you're going ahead with treatment, your option will be to remove this loosened fragment and check if it can be restored or not. So basically, there are two options when it comes to a crown root fracture. I'll tell these two options in detail. You don't have to by heart all this. You just keep these things in mind. By hearting will not will not let you reproduce the learned items. You have to understand the concepts and then you learn. Okay, so in a crown root fracture, I told you there are two conditions. It may involve the pulp, it may not involve the pulp. And also it can be restorable or it cannot be restorable. So if the tooth is restorable and if there is no pulpal exposure, okay, you remember, keep this point in mind. You imagine the clinical scenario, that is, if the tooth is restorable and if there is no pulpal exposure, what you do is that you cover the exposed dentine with glass ionomer cement. Okay, and if the tooth is restorable and the pulp is exposed, you do a pulpotomy or a root canal treatment depending upon the level of fracture as well as the root development. Okay, so if the tooth is restorable and there is no pulpal exposure, what you do? You cover the exposed dentine with a glass ionomer cement. If the tooth is restorable and if the pulp is exposed, when the pulp is exposed, you have to go for a pulpotomy or RCT depending upon the level of fracture and root development. Okay. Now, the second option in a crown root fracture is that if the tooth is unrestorable. If the tooth is unrestorable, what you do is that you extract this loose fragment. Whichever fragment is loose that is there, you extract the loose fragment without damaging your permanent tooth bud, and you leave the rest in situ, or you can extract the entire tooth. Okay, so this is the treatment option of a crown root fracture in the case of a primary dentition. So you keep in mind, you have two options. If the tooth is restorable and if the tooth is non-restorable, and if it is involving the pulp, not involving the pulp. If it is not involving the pulp, you can cover it with dentine and then restore it with GIC. If it is restorable and if it is involving the pulp, you go for a pulpotomy or RCT depending upon the involvement of your dental pulp as well as the root development. And if it is unrestorable, you can either extract that loose fragment or in ultimate case, you can extract the entire tooth. So this is how you manage a crown root fracture in primary dentition. Now moving on to the next fracture, that is root fracture. So root fracture in the case of a primary dentition, the management of the root fracture depends upon the location of the fracture. So usually the primary tooth root fracture, usually it occurs in the mid-root to apical third region. Okay, in the case of a primary dentition, root fracture is most likely seen in the mid-root to apical third region, and the coronal fragment, that is, this is the fracture line, the coronal fragment, it may be mobile or displaced. So because of that, there is occlusal interference also in root fracture. Now we'll see how we manage a root fracture in the primary dentition. Now, again, you don't have to by heart this. You imagine the clinical scenario and read, so that then only you will be able to answer these kind of problem solving questions. So you imagine the clinical scenario and then you read this, and then you listen to what I'm saying. Okay, so the root fracture we have mentioned, if the coronal fragment may be displaced or may not be displaced, right? If the coronal fragment, if it is not displaced, you don't have to do any treatment for a root fracture in primary dentition. Okay, and if the coronal fragment is displaced and if it is not excessively mobile, you leave it for spontaneous repositioning. Okay, now, if the coronal fragment is displaced and it is excessively mobile and also it interferes with occlusion, you have two options. First one is to extract only that fragment and the apical fragment can be left to be resolved. The second option is that you can reposition the fragment and you can give a flexible splending for about 4 weeks. Okay, so that is it about root fracture. So in root fracture, the things that you have to keep in mind is that whether your coronal fragment is either displaced or not. If it is not displaced, no treatment is needed. And if the coronal fragment is displaced and if it is not excessively mobile, you can leave it, you can leave the tooth like that only. Now, if the coronal fragment is displaced, excessively mobile and interfering with your occlusion, you can either extract the fragment or you can reposition the fragment and give a flexible splinting for about 4 weeks. Okay, so that is it about root fracture, and this is how you manage a root fracture in a primary dentition. Now, moving on to the next fracture, that is the alveolar fracture. So alveolar fracture means it is a fracture involving the alveolar bone. That is either the labial part, the labial plate or the lingual plate may be involved, or it may extend even to the adjacent bone. So you keep in mind alveolar fracture. So what is happening? You can see mobility as well as dislocation of your alveolar segment, and also there will be occlusal interference. And the fracture line, it may be located at any level. Sometimes it may involve the primary tooth level, or sometimes the alveolar fracture line may extend into your permanent successors level. Anywhere it can extend to, right? So that is about the clinical findings that you see in alveolar fracture. And now we'll see how we manage an alveolar fracture. So whenever there is an alveolar fracture affecting the primary dentition, you should always keep in mind that you reposition the segment and display segment, and then you go for a splinting. Then you stabilize the segment for about 4 weeks and you monitor the tooth and fracture line. Okay, that is how you manage an alveolar fracture in the case of a primary dentition. So that is how we manage the various hard tissue fractures in the case of primary dentition. Now we'll see the periodontal injury. Somebody has asked me to mention again about the periodontal injuries. Now we'll in detail go about each of the periodontal injuries. So the first injury is concussion. Concussion, I've already mentioned what is happening in concussion. There is no mobility, there is no displacement, but there is only marked reaction to percussion. Okay, concussion means marked reaction to percussion. So you can see that the tooth is having a normal mobility with no sulcular bleeding. Okay, so what should be your treatment option for concussion? You don't need any treatment. Okay, you don't need to intervene the condition. You have to just wait and watch. Okay, so that is how you manage concussion. Concussion means there is only marked reaction to percussion with no mobility and displacement. Okay, so in the case of concussion, you don't have to do any treatment. You have to just wait and watch. Now, moving on to the next periodontal injury, that is subluxation. Whenever the word luxation comes, you keep in mind the tooth is mobile. But there is no direction mentioned in subluxation. So that means that the tooth is not displaced. Okay, so in subluxation, the tooth is mobile. That is, there is abnormal mobility of the tooth, but there is no displacement. And also the tooth is again tender to touch and has got increased mobility. So in the case of subluxation, you will also see bleeding from the gingival crevice. Okay, so how do you manage subluxation in primary dentition? Again, in primary dentition, subluxation, no treatment is needed. You just have to wait and watch. In the case of periodontal injuries, you always advise that you give certain patient instructions, like you advise them with soft diet, advise them use of soft toothbrushes, advise them use of chlorhexidine mouth rinses either twice a day for around 1 week, so that better oral hygiene will be maintained. That will again helps in healing of your periodontium. So you have to give proper instructions to your patient following a dental trauma. Okay, so that is it about subluxation. Now, moving on to extrusive luxation. So in extrusive luxation, you can see the picture, the tooth is partially out of the socket. What is the difference between extrusive luxation and avulsion? Avulsion means the tooth is completely out of the socket. Okay, in avulsion, this tooth is completely out of the socket. In extrusive luxation, it is only partially out of the socket. So because of that, what you see is that the tooth will appear elongated. Because of this extrusion, you will see more of the root aspect of the tooth also. So you can see that the tooth appears elongated and also it is excessively mobile. Luxation means it is mobile. So it is mobile and also it is displaced out of the socket, partially displaced out of the socket. So because of that, what can it lead to? It can lead to occlusal interferences. So in the case of extrusive luxation, radiographically, you'll see a widened periodontal ligament space. Okay, radiographically, you see a widened periodontal ligament space in extrusive luxation. Now, how will you manage extrusive luxation? And if the tooth is not interfering with your occlusion, you will leave the tooth to spontaneously reposition itself. And if the tooth is excessively mobile or extruded more than 3 millimeter, then you have to extract it under LA. If it is not interfering with the occlusion or if it is only slightly mobile, you just leave the tooth to spontaneous realignment. And if the tooth is excessively mobile or if it is extruded more than 3 millimeter, you go for extraction under local anesthesia. In any injury, extraction should be your last resort. That is, if you have no other choice of saving the tooth, then only you go for an extraction. Okay, so that is it about extrusive luxation. Now, the next injury is a lateral luxation. Now, what do you mean by a lateral luxation? Lateral luxation means it is the displacement of the tooth in any direction other than axial. Okay, so the most common feature that you see in lateral luxation is there is a high chance of occlusal interference. So your management will vary depending upon the occlusal interference it resulted. Okay, so if a laterally luxated tooth, if it does not cause any kind of occlusal interference, you can allow the tooth. That is, you can just wait and watch, or the tooth is allowed to reposition on its own. Usually, it will reposition within 6 months. Okay, within 6 month time period, usually if the tooth, you allow the tooth to reposition on itself. Now, in situations of severe displacement, severe occlusal dislocation and all, what you do is that you have again two options is there. First option is that if you can extract it if there is a risk of ingestion or aspiration of the tooth. And the second option is that you can reposition the tooth in position and give a flexible splint for around 4 weeks. Okay, so that is how you manage a lateral luxation. So lateral luxation means the tooth is excessively mobile. Luxation means the tooth is mobile and also the tooth is displaced in any direction other than the axial direction. So how do you manage a lateral luxation? If there is no occlusal interference caused due to the luxated tooth, then you can wait for the tooth to spontaneously realign itself. Usually it will occur within 6 months following trauma. Now, in the case of severe displacement, either you can do an extraction if there is a severe risk of ingestion or aspiration of the tooth, or else you can go for a flexible splinting of about 4 weeks. Okay, you can take support from the non-injured adjacent tooth and you give a splinting for around 4 weeks. That is how you manage a lateral luxation. Now, moving on to intrusive luxation. So intrusive luxation means the tooth is displaced into the socket. So in the case of a primary dentition, as I've already mentioned, whenever there is an intrusive luxation, you keep in mind you have your permanent tooth bud that is erupting from above, right? So your management, so whenever you pick an option, you should be able to pick the adequate option among the same. Now, the intrusive luxation, how do you manage intrusive luxation? If the apex is displaced towards or through the labial bone plate, you can again, the tooth is left for spontaneous repositioning. And spontaneous repositioning in the case of an intrusive luxation, it usually occurs within 6 months to 1 year. Okay. So spontaneous realignment usually occurs within 6 months to 1 year. Whenever there is an intrusive luxation, there is extensive damage of your periodontal tissue as well as your adjacent bone too. Okay, you have to keep that too in mind when it comes to the intrusive luxation. In the other pictures, you can see that this is your PDL area, your fiber attachment and bone and all. So here there is damage. There is damage to the periodontal area as well as the area, the bones also. You can see small minor cracks can be seen in the case of an intrusive luxation. Okay, so the treatment for an intrusive luxation is that the tooth is left for spontaneous repositioning, which usually occurs within 6 months to 1 year of age, 1 year following trauma. Now, Moving on to the last injury, that is avulsion. So avulsion means the tooth is completely out of the socket. So I repeat, somebody was asking about avulsion and extrusive luxation. Avulsion means the tooth is completely out of the socket. It is otherwise referred to as X articulation. You should be also knowing that name, because if you get X articulation in the option and if you don't know that it is avulsion, you might miss your chance. Okay, so keep in mind avulsion is otherwise called X articulation, and in the case of a primary dentition, it is not recommended to replant an avulsed primary tooth. So according to the International Association of Dental Traumatology's guidelines, it is not recommended to replant an avulsed primary tooth. Okay, so that finishes the main injuries. And also one more thing that you need to know in avulsion is that if an avulsed tooth is usually avulsed tooth means the tooth is completely out of the socket, right? So there is a risk that it can get embedded in your soft tissue of the lip, cheek, tongue, or it can be ingested, or it can be aspirated. And if you don't see an avulsed tooth, can you just leave the patient like that? No, there is a chance of the ingestion or inhalation of the tooth. So you should refer the child for a medical evaluation. Okay, so that is one thing that you need to know in avulsion. So in avulsion, keep in mind, it is not recommended to replant an avulsed primary tooth. Now we'll see what are the basic reaction of a tooth to trauma. So the first thing is pulpal hyperemia. Pulpal hyperemia is actually a minor congestion that is seen in the pulp a few hours following trauma. Then you can see internal hemorrhage, or you can see root canal calcifications in the dental pulp, or you can see internal resorption, external resorption can be seen, pulpal necrosis, ankylosis. All these are reaction of your primary tooth to trauma. Okay, now this is the picture of an internal hemorrhage. Okay, this you can see there is a slight discoloration in the tooth, and this is a picture of an internal hemorrhage in a primary tooth. So as I've mentioned, hyperemia means it's a small congestion in the pulp few hours following the trauma. So this congestion and increased pressure that will lead to the rupture of capillaries, and these capillaries, and from when this capillaries rupture, there will be escape of red blood cells with subsequent breakdown and pigment formation, and that is responsible for the discoloration of the tooth. Usually this is evident within 2 to 3 weeks after the injury. And generally, this discoloration or this reaction is reversible to the degree, even though the crown may retain some of the discoloration for an indefinite period. Okay, so whenever there is an hyperemia and increased pressure, there will be rupture of the capillaries that will lead to escape of the red blood cells with subsequent breakdown and pigment formation that is responsible for the discoloration of your tooth. Okay, usually it is considered reversible. Now, next thing is the internal resorption. So internal resorption, it is by the odontoclastic action. And again, it is referred to as the pink spot by Mummery. Because here you can see, whenever there is internal resorption affecting the crown, the vascular tissue of your pulp, it will shine through the remaining thin shell of the tooth. That is referred to as the pink spot. So following trauma, you can also expect internal resorption. Now, the next thing is the reaction of a permanent tooth bud to injury. So, whenever there is a primary tooth trauma, there is high chance that it can also affect the developing permanent tooth bud. So, the most likely problem that it is going to cause with the permanent tooth bud is the hypocalcification or hypoplasia of the tooth. What do you call that hypoplasia? That typical hypoplasia, that is a small pigmented hypoplastic area, is referred to as a Turner's tooth. So how is that hypoplasia resulting? Because most likely that would be the time where the ameloblasts are laying down the enamel for the permanent tooth bud. So in that case, what will happen? It will affect the ameloblast and will lead to hypocalcification or hypoplasia of your permanent tooth bud. And that hypoplasia is referred to as a Turner's hypoplasia. Okay, so I hope I am clear to you all about trauma. So this is all about the trauma to the primary dentition. So you keep in mind about the various injuries that you see in the tooth as well as in the periodontium area. Always read the question completely before you jump into your answer. You analyze the clinical scenario in your mind and then only you go into the answers. Okay, so I think we'll start with today's questions. So the first question is, Maxillary central incisors of a 2-year-old child were traumatically intruded 2 millimeters apically. The immediate treatment would require careful removing of the both incisors, repositioning of the intruded tooth, making the patient as comfortable as possible without disturbing the tooth, repositioning and splinting the intruded teeth with preformed bands on both central and lateral incisors and a contoured labial archwire attached to the band. So what is the answer? Yes, it is making the patient as comfortable as possible without disturbing the treat. So here the key point is immediate treatment. Okay, you keep in mind it is immediate treatment, and your immediate treatment is always to wait and watch. Whenever there is an intrusion, you keep in mind the tooth may spontaneously re-erupt within 6 months to 1 year. So your treatment will be to wait and watch. So the best option among the four is option C. Very good. You're going good. Now, moving to the next question. A 4.5-year-old child has fallen within the past 2 hours and traumatized both maxillary central incisors to the point that they are extremely mobile. The treatment of choice would be, you read the options properly and then only you give me the answer, okay? Option A, extract them because they would be lost soon anyway. Do nothing and observe periodically. Immobilize and with a splint and do nothing more. Check radiographically for root fractures, and if no, proceed with a splint and periodic examination. So which among these four is the correct answer? I am getting different responses. You read the question properly and tell me the answer. Which among, see, whenever you get a question like this, you should always pick the best option among the four. Which is the best option among the four? It is definitely option D. See, why it is not option A? See, the child is only 4.5-year-old, right? The new incisors will be erupting in its position by around 6 to 6.5 years of age. So what about that 2 years of psychological trauma that the child will be having because of the missing 2 central incisors? Okay, so you cannot go ahead with option A. Now, do nothing and observe periodically. Can you go with that? Because the tooth is extremely mobile. Can you just sit, wait and watch if the tooth is extremely mobile? No. So you can eliminate option B. Now, the third option is immobilize with a splint and do nothing more. See, immobilize is okay, but do nothing more. Is that okay? No. You have to see. You have to see whether you have to review the patient and see what are the outcomes of the tooth, right? So the best option among these four is option D. So whenever you get a question like this, sometimes you may see that the other options are also right, but you have to pick the best option among the four. So here the correct answer is option D. I hope I'm clear to you. Now moving on to the next question. A 3-year-old child has a central incisor that has turned bluish black. There is a small radiolucent area at the apex of the tooth. Ideal treatment is, read the question correctly, read the question properly and answer. A 3-year-old child, central incisor. Yes. Yes, excellent. Your answer is right. It is pulpectomy with zinc oxide eugenol. Why? Because it is clearly mentioned that there is a radiolucent area at the apex of the tooth. So whenever there is a radiolucent area, what does that shows? A radiolucent area shows it is an infection extending into your root area, right? So you cannot go along with the pulpotomy. You have to go with the pulpectomy. So your option, all of you are right. So the correct option is option C. Now, trauma to the teeth resulting in loosening but no displacement is, yes, it is subluxation. What do you mean by concussion? What is concussion? Percussion. Concussion means marked reaction to percussion. There is no mobility, no displacement. Subluxation means there is mobility, no displacement. What is the other name of avulsion? The other name of avulsion is X-articulation. Yes, avulsion is X-articulation. What is the central dislocation? What do you mean by central dislocation? Yes, central dislocation is intrusion. What was peripheral dislocation? Peripheral dislocation is extrusion. Central dislocation is intrusion. Peripheral dislocation is extrusion. Okay, please understand that like that only. Central is intrusion. Peripheral is extrusion. Now, fracture in the upper central incisor involving enamel and dentine with pulpal involvement falls under which LS classification? Yes, it is LS class 3. Somebody has mentioned it as LS class 9. What was an LS class 9 fracture? LS class 9 was? Yes, primary tooth. What was, which class was avulsion? LS class? Yes, LS class 5. Root fracture is LS class? Yes, good. Very, very good. Now we'll move on to the next question. That is, a primary incisor that is traumatized often discolors subsequent to the injury as a result of? Yes, correct. It is extravasation of the blood elements in the pulp chambers. Okay, so that finishes today's trauma session. So I hope I am clear to you all about trauma. In traumatic injuries in the primary dentition, whichever question that comes to you, you read the question properly. Every single word is a clue to your answer. If it, whether the management, they are asking about the emergency management or they are asking for a long-term management, anything, the every single word in your question is very, very important in answering all the questions regarding trauma. Okay, I hope I am clear to you all about trauma session in primary dentition. Hoping to see you all in the contact sessions later. And I hope Dr. Hima is there. Over to you, Dr. Hima.
Thank you, ma'am. Tomorrow there will be an inauguration of our NEET MDS 2021 regular batch, and an orientation program is held tomorrow. And the inauguration address will be given by Dr. Baby John. He's a dean in periodontics, VMS Dental College, Salem, and he's the vice president of Indian Society of Periodontics and Preventive Dentistry, and he was a principal of JKN Dental College, Tamil Nadu. He's also a great guest lecturer in WHO for the Conference of World Health Aging, and he's a reviewer in both national and international journals. So to attend our inaugurational program tomorrow, please log into our Zoom session or live YouTube session at 8 p.m. So hope we'll see you guys tomorrow. And to join our course, please contact the number 9895021337. Thank you, ma'am. Thank you so much.
Good night. Take care.